So good evening, everyone. Welcome to another Pan-India Pediatric Neuroscience sessions. We have around 11 cases for discussion today. And the first 6 cases are from Dr. Vivek. So I'll let Dr. Vivek start off with his first case.
Okay, so this is a 8-year-old boy who had uneventful perinatal period and had tonic seizures. So in the first few months, anyhow, one tends to have very sort of simplistic seizures, tonic, clonic, myoclonic, So he had tonic seizures from 3-month age. So there was no focality, multiple times a day, multiple anti-seizure medicines tried. There were periods when he will be off, he will be seizure free for up to a year, but then the seizures will restart. And over the last 5 years, so since he's 3 years age, since his myelination is complete, the seizure semiology is more visible, where events will be associated with behavioral arrest, oromotor automatism, some left hand tapping, and expressive dysphasia. He's right-handed. And in spite of his seizures from 3-month age, he does have moderate ID. He's not autistic. So I'm going to school ambulant, which is very, at least in my experience, odd for a genetic cause of developmental and epileptic encephalopathy, because if a child has a genetic cause, you will have a child with so many seizures should be so significantly affected. He's not. His EEG doesn't localize, has multifocal epileptiform discharges, more on the left side, but not in the temporal region. So he had an MRI brain done. One was done quite early on in his life, which was not that good. So we repeated it recently, epilepsy protocols. So there was a cleft temporal lesion, if that is the cause. We have sent his whole exome also.
Okay. So here are the MRI images. Nothing in the supratemporal brain parenchyma, the deep brain nuclei, and also the infratemporal regions. Coming down to the temporal region on the left, you can appreciate that it is slightly more bulky in comparison to the right. The amygdala is bulky, it demonstrates some low signal changes on the player and T1 sequences. There appears to be a cyst along the medial aspect. No restricted diffusion. There are changes of blooming on the gradient sequences, predominantly along the medial aspect of the lesion. T1 again, it appears to be a solid and a cystic lesion, though we don't have contrast to confirm that. Again, on the sagittal images, you can appreciate a cystic lesion, predominantly cystic lesion, with some solid components along the medial aspect. And the coronal flares, again, you can appreciate that the temporal lobe is edematous, more bulky in nature, and demonstrates this lesion in the medial temporal lobe. It is partly cystic and possibly solid, with areas of mineralization. So based on these findings, and given a history of refractory seizures, think of neoplastic lesions resulting in the temporal lobe epilepsy. The most common ones in pediatric age group are the gangliogliomas. As you can see in the examples, they usually present with a solid and cystic components, and they usually have calcifications with them. The DNS are differential. They have a more bubbly T2 hyperintense appearance, but calcification is less common than seen in gangliogliomas. The other possibilities are oligodendrogliomas, though they are slightly more larger and not as well circumscribed. Again, calcifications are common in them, but they are present in a more adult age group, and the frontal lobes are more common. Pleomorphic xanthoastrocytoma is another differential, but again, you can see it is more along the cortex, along the periphery. It presents with a mural nodule and a cyst. So based on the images, I would think ganglioglioma is our first possibility, with these as the other differentials. There's a possibility that it can be present with a focal cortical dysplasia, that is an FC2 type 2B, which can be associated with a glioneuronal tumor. So at this point, I'll open the case for any further comments and discussion.
So exome was sent before the MRI was done. There was a study I'm doing on DE. So we are doing whole exome prior for all patients. So before the MRI, it was already sent. So maybe I wouldn't have sent it after if the MRI was done before. So we are planning to call him for our epilepsy surgery meeting. So to see if family agrees.
Okay.
Nihaal, if I'm correct, this is a calcifying area.
Yes.
Yes. It's rather unusual in a focal cortical dysplasia and in DNET as well.
Yeah, it is more commonly seen in gangliogliomas.
Anyway, this patient is a candidate for epilepsy surgery, and then we will have his done.
Yes. All right. Okay, thank you. Moving on to our next case, Dr. Vivek.
So this is a 3-year-old boy who, again, no perinatal insult, good weight baby. So antenatally also there weren't any issues. Baby was well at birth, and parents noticed slow progress over the first year. And there was more focality. In some left side was more affected. He cannot walk, but when he sits, he has left-sided cortical fisting, left side more affected, and more of a Worcester drought syndrome sites, morphology, where he keeps his mouth open, tongue movements are less, he drools, there is no speech, but with left side more affected and cognitively better. So he's like a 6-month-old baby physically, but cognitively he's around 15 to 16 months age. So I did an MRI thinking, is there a peri-Rolandic damage antenatally? So for me, it was more of an acquired cause, but because of the focality, because he had more one-sided involvement. So this was the MRI, but I'm still not sure this is genetic or acquired.
Yeah. So we have the MR flare axis sequence on top, and you can observe that there are chronic ischemic changes with porencephalic dilatation of the right lateral ventricle, reduction in the periventricular white matter, ventricles reaching up to the insular cortex, cystic foci in the basal ganglia, and you can again appreciate there's another cystic foci in the left parietal region, which is almost like a porencephalic cyst joining the external CSF. So almost giving an appearance of a sidencephalic type of an appearance, which can be a better demonstration on the coronal images. And on the posterior fossa, you can appreciate that there is ipsilateral variant degeneration of the brainstem due to the chronic ischemic change in supratemporal brain parenchyma. The corpus callosum is thinned out with a posterior to anterior gradient. So overall, there are chronic ischemic changes, I would say, in the bilateral cerebral hemispheres, the perisylvian region on the right, and also in the left parotoccipital region. No acute abnormalities on the gradient sequences. Possible slight here minor areas of blooming on the along the lateral aspect of the cystic foci, but other than that, I cannot appreciate any areas of mineralization or hemorrhage. So overall, a chronic changes with variant degeneration and some cystic porencephalic dilatation and possible sidencephaly. I would think of that as a acquired insult, but just to rule out and to evaluate genetic causes, call for A12 mutation. When we see the changes of porencephaly, sidencephaly, bilateral involvement, they usually are associated with calcification and hemorrhage. And other systemic findings, as demonstrated here, are commonly seen in call for A12 mutations. So that is the only genetic cause I could think of that could cause an antenatal damage or perinatal damage. Any Dr. Vivek, any systemic findings pertaining to the collagen vascular disorders?
Yeah, so clinically not. So I've not looked at the renal, I've not evaluated, but there's no history. And child is more spastic rather than flexible. So these are the things. And he doesn't have a cataract. I got his eye examination done, and there's no history of cataracts or early stroke in the family. It's just the baby was not an IUGR, good weight baby. So it's just what could have happened. That's just acquired causes. So it's just an unusual distribution of the lesions, which made me think.
Can I add something? I agree. Collagen 41A2 is top on the list of genetically triggered disruption affecting multiple sites and leading to schizencephaly. There are rare reports about other genetic causes involving genes involved in the coagulation cascade and also in the biogenesis of thrombocytes. So if collagen A comes back as normal, it does not exclude a genetic trigger, but overall this is acquired.
Thanks, Eugene. Any other comments if anyone wants to? Okay, if there are no further comments, we'll move on to our next case.
Yeah, so So this is a child who was admitted with one of my colleagues somewhere else. They just came for a OPD outpatient visit for a opinion. So she has been, she just came 5-7 days back, was unwell for 3 weeks with documented fever for the first 10 days of the illness, severe headaches, more morning vomiting, so more like raised pressure symptoms. So she got admitted. Her CSF pressure was slightly raised, but it was not measured, formally. And there was evidence of lymphocytic pleocytosis with a normal sugar. So sugar was not low, with a slightly high protein. No history of tuberculosis in the family. Chest X-ray was normal. Monthly was negative. ESR was high. The ESR was 100. She does have a history of arthralgias over the last 2 years. Arthralgia. So that was there. More in the mornings. It was not convincing. Just that daughter said both ankles sometimes pain. But this was more like a 3-4 weeks illness with a high ESR and CSF more suggestive of viral meningitis-like process. So she got an MRI done, and the CSF was also sent for. Do you want me to give the CSF result, or we look at the MRI first?
No, we look at the MR first.
Right.
Yeah, so we have the MR. On top of the flare axial sequences. I cannot appreciate any abnormalities in the frontal parietal regions. Some equivocal changes, but this is likely due to partialing. Deep brain nuclei again demonstrate no focal signal abnormalities, no volume loss. Coming down to the brainstem, you can appreciate that there is these hyperintense changes in the almost symmetrical in nature in the cerebral peduncles on both sides. Coming down, it is extending up to the, it's also seen in the dentate nuclei and also along the ventral aspect of the medulla oblongata. No corresponding restricted diffusion of the brainstem abnormalities. On the sagittal images, the corpus callosum is slightly thinned out. I cannot appreciate any focal abnormalities in the visualized cervical cord. And these are actually zoomed in images of the optic nerves. Again, not very satisfactory for any edema or optic nerve changes. Contrast wasn't done. Only these areas in the proximal optic nerves appear slightly hyperintense, but I would confirm that with the contrast image if it is optic neuritis or not. I don't think clinically it presents with any visual abnormalities. So based on these imaging findings, think of a possible Rhomboencephalitis. The common infections in pediatric age group are the enterovirus 68 and 71, Epstein-Barr virus, HSV1 and 2. The uncommon ones are Epstein-Barr virus and cytomegalovirus. In bacterial causes, Listeria is the most common cause. Demyelination, isolated involvement of the brainstem, it is less commonly seen. There are usually other findings in the supratentorial brain parenchyma, optic nerves, and the spinal cord. This is from literature. You can see that the brainstem changes of the various demyelinating lesions, the common ones, the MOG and NMOSD and MS, but these are again usually associated with supratentorial or other optic nerve or spinal cord abnormalities. And you can appreciate that what, as seen in our case, the images are slightly, the hyperintense lesions are slightly more, not as well circumscribed as seen in our patient. So I would put demyelination as a second differential rather than the first, and think of Rhomboencephalitis related causes. Dr. Ved, do you want to give the CSF?
Yeah. So HSV1 and 2 was, so there was a panel, viral meningitis panel, which was done. So that covered HSV1 and 2, which was normal. CMV was negative. Enterovirus was negative, but I won't believe enterovirus being negative in CSF because of very low sensitivity. So one has to do a nasopharyngeal PCR if one really needs to think of it. But EBV copy numbers were very high, significantly raised, more than 22,000. We did anti-MOG, which was negative, NMO anti-MOG. In the blood, we did VCA IgM for EBV, which was normal, so negative. So I'm not sure if it's an acute phase. That's why the antibodies have not developed. And ANA was negative because of the arthralgia. We did it, and ACE levels were normal because ESR high, and so just autoimmune work. That's what was done. And JE was done in the blood, which was negative. So just have people seen it? This sort of, we gave her steroid 3 days anyhow. because there was no diffusion restriction, so more of an inflammatory process. Because when you
Yeah.
think of an infection, you should have more of a cytotoxic edema as well. This looks more like a para-infectious process because there's no diffusion restriction. You know, if a virus causes it, there should be some diffusion restriction. Is that right?
At what time frame was the scan? From the
So
onset
12
of
days
symptoms?
into the illness, when like the day CSF was done, so
Yeah.
so she was
12 days,
symptomatic at the time.
yeah, 12 days might be going into the para-infectious realm. I think within a week or so, diffusion changes can be expected, but we're going into the second week, so
But blood IgM was negative for EBV. That's quite sensitive.
I'm not saying EBV, I'm just saying for infection in general.
Right. And ferritin was normal in blood. Yeah,
You can.
I mean, the only one thing I was just suddenly wondering with the EBV viremia, could this be either primary or secondary HLH?
So ferritin, I think I meant ferritin in blood was normal.
HLH, you normally don't get CNS HLH. You don't normally get any systemic manifestation. It just I thought it was quite interesting with the EBV viremia also in the CSF. So do you feel that the 3 days of steroids is enough to? I mean, I think we have to be pragmatic. So you could do the genes. It would take weeks. It could also be secondary.
14-year age. Yale. Is that Yale? 14-year age.
Yeah. We've seen many of those teenagers, and actually they present like this. So the teenagers are, if anything, maybe less likely to have systemic. We see them presenting with CNS only, but also, and Kish will remember, we had a number of patients that looked. She doesn't, but we had a number of patients that looked very typical of HLH that were genetics negative. So I think with all of these conditions, you can get secondary HLH secondary to an infection, the same mechanism. We had one patient that we thought a couple of years ago maybe it was mycoplasma related, all the genes were negative, and he did okay. But I'm just, my only worry, if this is, I don't know, I think it's a bit atypical for enterovirus, the lesions, I feel. And if anything, the MRI looks a bit more inflammatory than infective. The radiologist, please correct me, would expect a bit more distractions. And I don't even know how she's doing. Is she clinically in intensive care, or is she clinically at the moment now?
So she's clinically well. She's at home. So
exactly.
She's on oral steroids.
That would go against any of the viral brainstem encephalitis, because these patients with, if you have enterovirus, I mean, you're normally in the intensive care, you're not going to be walking around at home. So the discrepancy between the scan and how she's clinically would go, I feel, a bit more with inflammation than infection. And my only question is really, we know the antibodies are negative. There's clearly, a systemic immune response with our raised ESR, although, it doesn't look typical of sarcoid or lupus also. But should we give a bit of a longer, I mean, you could consider, should you give a bit more longer steroid course?
Yeah, she's on oral steroids. So 3 days IV.
Oh, okay. And then you continue with some steroids, and then maybe scan in 6 weeks?
Three. I was thinking 3 months. I can do in 6 weeks. So
6 weeks, I think, will be interesting to see I mean, she's 13, she could manage it easily, no?
Yeah, that's fine. So odd for HLH, isn't it? The neuroimaging cerebellar lesions are not there, but again, I haven't seen any HLH, or maybe one. And lesion should.
The EBV viremia, a lot of the time goes with some of those HLH, because you get EBV driven HLH. So if the BBV is driving this, it's just one mechanism.
The Duncan's disease, right? So, those HLH, CNS HLH, secondary, are they not sort of contrast enhancing lesions in the parenchyma rather than in the brainstem with no diffusion restriction? Is that not odd? Or cerebellar lesions? Cerebellar lesions.
No, it's a lot of the time it's brainstem and cerebellar. I mean, if it's and I think it's atypical. I mean, as I said, the main thing that makes me think about this in this case is this EBV viremia. Can I just ask, was the EBV tested after the steroids or before the steroids?
Before steroids. So
okay, so
steroid
it's
start
clear
related.
it's not that the steroids made it higher or anything. So it's just a
No.
bit unusual. So that's the only thing that mainly made me think of it. And I think the imaging is not like excluding it. So you can see some funny HLHs like this, but I mean, I think it's up to you. If it's easy to do just the HLH genes, it's maybe worth just to kind of tick that box. But equally, you know, you could wait and see how she's doing. And if she has another episode, I would do it.
Sure. Thanks. We'll do MRI in 6 weeks.
It very much, because the fact she's clinically so well goes very much against infection. You know, if it was an infective agent giving you these brainstem changes, you would have been much more affected, I think.
Sure. So we'll do MRI in 6 weeks. I'll update.
Yeah. Yeah, next case, Dr.
So this is a 13-month-old female child. Unfortunately, I don't have a photographs of video. I did ask father today, he couldn't send. So global delay, head larger as compared to the body, slight hemihypertrophy right side, but on the so not convincing, but maybe it's there. She has a long face, so midfacial hypoplasia, bulbous nose. She has a central hypotonia and marked hyperlaxity. And there were no, so she's just a delayed child who is progressing slower than what she should be. So she's around 6-7 months age with her development, sitting, some interaction, some babbling. So she had MRI brain done. Sorry, the investigation probably wrote first, but maybe we could see the MRI first.
Okay.
So
Okay.
the MRI was done as part of workup for the delay.
Yeah. So again, on the MRI, just going on to the lower panel, we have some degree of cerebral atrophy, some reduction in the volume of the corpus callosum. Again, brainstem changes, subthalamic nuclei, the middle aspects of the red nucleus, the decussation of the superior cerebral peduncles, the middle cerebral peduncle demonstrates this restricted diffusion with corresponding hyperintensities on the T2 sequences. You can again appreciate the abnormalities of the midbrain on the parietal images. So these central brainstem changes and the cerebellar white matter changes with a degree of volume loss in the supratemporal brain parenchyma. Yeah, Dr.
So we did a
lactate.
Yeah, so we did a blood lactate homocysteine, which was normal. Urine organic acid was normal. TMS showed very low, carnitine really low. So next slide shows the values, right? So 14.4 and free carnitine 7.7, less than 8 is, think of carnitine deficiency disorders. There is a rider though. This lab where we do it, sometimes you do get low levels. This is too low, but you do get low levels. And I did ask them, and they said if you transport it and it's done in 2-3 days, the TMS carnitine does show lower levels than normal. So, so maybe not. So it might be the cause, because the presentation is not looking like carnitine deficiency disorders where you have quite early on in life hypoglycemic episodes and organomegaly, which is not there, and encephalopathy episodes. So maybe might have one, but she hasn't had till now.
Yeah, carnitine on imaging, I couldn't find much on literature. There were 2 case reports. This is from 2015. You can appreciate that the deep white matter and the brainstem and cerebellar white matter have cytotoxic edema. Another report demonstrated these frontal white matter confluent changes, and also the anterior basic ganglia demonstrating cytotoxic edema. But other than that, I could not find any changes of any other findings for primary or secondary carnitine deficiency. Based on the imaging, I would think of a metabolic disorder, but I cannot ascertain or narrow it down to which metabolic disorder it fits into. Any lactate was normal, is that right, Dr.?
In the blood.
So mitochondrial, okay. I'll open the case for discussion.
I agree. This is likely a genetic or metabolic condition. The findings are not specific. I have a paper in mind. I can't pronounce the name about the patient with PIGA deficiency, PIGA deficiency.
Yeah.
This is a group of disorders which are responsible for anchoring proteins in the Golgi apparatus and in the endoplasmatic reticulum. I think you can only make or exclude the diagnosis by exome sequencing.
Sure.
Do we check for the alkaline phosphatase in the liver?
Yeah, alkaline phosphatase.
Yeah.
We can check that, right? Because that can be affected. Yeah.
Yeah.
Is that high or low? I forgot.
Elevated.
I don't know. Elevated. Okay. So we'll send exome. The family would be able to do it. So I'll update.
Okay. Sure.
They started Carnitine for now.
Okay.
Right.
All right. We'll move on to our next case.
Yeah. So this is an unfortunate family actually. So a 3-year-old female child who has had one SIB death, a SIB who had died at a year age, who in 24 hours was developing normally and had a CNS involvement with posturing, hypoglycemia, ventilated 24 hours, but was brain dead the next day. So that was her younger sibling at 1 year age. And she also used to have a degree of failure to thrive from 6-month age. So at that time, diagnosis could not be made. So this 3-year-old female child, again, a normal development, but significant failure to thrive from 6 months, and was having hepatosplenomegaly with liver dysfunction. So for that, evaluation was done. And then she was found to have hereditary fructose intolerance at around 8 months age. But they were counseled and she had poor compliance with avoiding fructose. And then now 2 years later, she's in a viral illness. Again, the same history. Within 24 hours, she deteriorated, tonic posturing, ventilated, and she's brain dead. She's been withdrawn, like last week, withdrew care. And her younger sister, so there are 3 children. One died already. She's 3-year-old, and a younger sister. The day she deteriorated, the next day the younger sister deteriorated. So they ran with both the children to the hospital. The first one, this 3-year-old girl, has now passed away, but the younger one, somehow they could save, and because she was brought in early. So within 24 hours, both were admitted, and she has been discharged home, and she has survived. So I think this whole family has hereditary fructose intolerance, where one SIB has died, 2 have died, and 1 is alive now. And these are the MRI findings, but MRI was, because radiologist was not aware of the history, so he reported it as ANEC, acute neck crack, because of some hemorrhages which were seen. So I just wanted to put this up for hereditary fructose intolerance associated MRI changes when they acutely deteriorate.
So the MR, you can appreciate again a bilateral peninsular region. You have these hyperintense changes. The thalamus is predominantly in the centromedian regions. The mammillary bodies are involved. The posterior periventricular white matter. The brainstem demonstrates these hyperintense edematous changes. Cerebellar also is edematous. On the SWS sequences, there are some areas of blooming in the thalami, the mammillary bodies, the brainstem. You better appreciate the involvement of the corpus callosum on the sagittal images and also the brainstem predominantly along the dorsal aspect. So I think based on these findings, they might have reported as a necrotizing encephalitis because there are some areas of possible hemorrhage in the thalami, in the brainstem, and the mammillary bodies. Diffusion again, the thalamic changes, the perisylvian changes, mammillary bodies, dorsal brainstem, and some areas of the cerebellum, in particular, the dependent portions demonstrate these area restricted diffusion. For post-contrast study, I cannot appreciate any significant enhancement of the involved areas. So these are the changes for ANEC. They can present with these white matter abnormalities and also gray matter abnormalities, but the thalamic regions are usually more diffuse in presentation. Posterior fossa changes can also be demonstrated. Necrotizing in the form of hemorrhage or the ring-like enhancement on post-contrast study can be seen. Differentials for the imaging pattern, again, viral infections can present with these thalamic and white matter changes with necrosis or hemorrhage. I could not find any imaging findings of hereditary fructose intolerance, but this is from a metabolic textbook, and where they have described it to cause a CNS intoxication. So probably not sure if these changes are related to that primarily, or there is some component of necrotizing demyelination over there. Again, I don't think hypoglycemia is present in our case, which can be commonly seen in hereditary fructose intolerance. Is that right, Dr. Vivek?
Sorry, she was hypoglycemic.
Okay.
Yeah. Sorry, I missed. Yeah, she was hypoglycemic.
So no experience with this disorder and imaging findings. I would open the case for any further comments if anyone has seen these cases.
The ventricular prominence is probably because of the cerebellum compressing the fourth ventricle.
Yeah.
Right. Yeah. It's just the hemorrhages which are. I just saw a lesson for me that if a child has some failure to thrive, because fructose intolerance you won't diagnose often, and the younger sibling doesn't have any organomegaly. She does have. She also has failure to thrive, but no organomegaly. So if they come with this MRI, suddenly unwell, you think of neurometabolic, maybe think of fructose intolerance as well, even with the hemorrhages.
Did you find any cases in literature, Dr. Vivek? I wasn't able to.
No, I couldn't.
The first, okay.
Possibly.
Any comments?
Not
or
first.
age? Yeah. Out of location. Okay. If there are no comments, we'll move on to the next case. Yeah, please.
So this is just again to show the imaging findings and clinical question for treatment. So this is a day 25-old baby who became unwell 4 days prior to admission with high-grade fever and irritability, decreased refusal to feed, and then left focal seizure. The video would show up. Does it play?
Yeah.
Nihaal? So left focal seizures. I think both the videos are the same. So
okay.
Frequent seizures, more like if we go by definition in a bigger child, status epilepticus. And the child needed high dose of midazolam infusion. None of the conventional anti-epileptics, phenobab, phenytoin, levetiracetam, they worked. And then we did a CSF, which showed a bacterial picture, and the CSF PCR revealed group B strep. So group B strep for us in our country is not that common because we see more gram-negative as late onset neonatal meningitis as compared to in the Western world. So for us, this was not common, unusual, group B strep meningitis. And then there were these MRI changes. The child is actually doing much better now. She is on day 7 antibiotics. The interesting thing was, Nihaal will probably talk about.
Yeah, so on the MR on top, we have the diffusion weighted sequences. Some areas of diffusion, linear areas, restricted diffusion in the cortical or extraaxial subdural space. In the frontal region, some degree of restricted diffusion in the bilateral parietal regions along the cortex, splenium of the corpus callosum, the bilateral basal ganglia, and also the central white matter. Again, some areas of restricted diffusion in the right frontal region. Going on to the basifrontal region, the mammillary bodies, the medial temporal lobes, cerebral peduncles. On the flare sequences, you can appreciate that there are some areas of subdural collections on both sides, more along the right anterior convexity. Posterior fossa, if you see, there is some area, again, some subdural collection on in the parietal temporal lobes. On the SWS sequences, you can appreciate that there is some hemorrhagic components in the subdural space on the right. There's also evidence of sinus thrombosis involving the bilateral transverse sinuses and also the sigmoid sinus, straight sinus, superior sagittal sinus, sorry. Post contrast, on top are the T1 weighted sequences. And you have these changes of bilateral subdural empyemas, peripheral enhancement with central sparing, and also this thick nodular enhancement in the basal ganglia, leptomeningeal enhancement along the sylvian fissures and in the basal cisterns. Again, subdural empyemas on the right in the bilateral temporal lobes. These are flare contrast sequences. So again, contrast enhancement pattern is similar to the T1 weighted sequences. The subdural collections demonstrate hyperintense changes on the flare sequences. Again, on the coronal images, you can appreciate this thick nodular, almost confluent type of enhancement in the deep gray nuclei. So the question was, Dr. Vivek, if the basic ganglia changes are related to CVT, was that the question?
So yeah, two questions. So one is that is that so? The second was three questions. So second was these nodular exudates. One wouldn't give steroids, but I was wondering if I can give some dexamethasone for 2-3 days for so much of inflammation. And the third was about the collection. Does it need to be drained, or we just give antibiotic and maybe repeat it in 2 weeks' time and see if this can be treated with antibiotics? The child is better already.
So these are common presentation for Streptococcus. They can present with vasculitic ischemic, small vessel ischemic changes in the deep gray nuclei and periventricular regions. The leptomeningeal abnormalities, subdural empyemas are also common for pyogenic infections as seen in Streptococcus. Regarding the question of if it was a CVT or a deep vein thrombosis, there's nothing in the SWA sequence to demonstrate any abnormality in the internal cerebral veins or the deep veins. So I would not think that these are changes related to the deep vein thrombosis. If there are smallest ischemic changes or just exudates, as if you scroll the images, they actually go and join up to the basal frontal regions and also the basal cisterns. So if they are part of the inflammatory infective process, more likely
like
than a deep, more likely, yeah.
Arthritis, more like tubercular, like not tubercular, but same sort of. So globus also, so that's globus, right? Globus also same sort.
Yeah.
Okay.
And the clinical questions, I'll open it for one of the panelists to answer.
So subdural empyema to drain, and if any role of steroid, if one has so much of exudates.
Any experience, Eugene, Hale, or Dr. Lokesh, Dr. Kavita? They are online.
I have very limited historic experience in late onset based streptococcal. Maybe this was a selection bias. The outcome of these children was extremely poor, with hypothalamic damage and endocrine problems. So this, I would be very much concerned overall. But this may be a selection.
Maybe Eugene, can one maybe give steroid? Is that something which would be wrong to do, or give a trial of few days just to help the inflammation? So much of exudates.
There is no evidence. I would do it. I would try. Yes.
Yeah. Thanks. And any comment on the evacuation? Subdural, is it large enough to remove, or one empyema? Is it a rule that empyema should always be evacuated, or one can give antibiotics a chance?
Generally, if there is no fever and no focal seizures underlying the parenchyma irritation, so I think we can always wait if the child is improving.
Okay, sure.
And although Strep is there in India, but we have had 2 children, all young infants only, with group B strep. Definitely, we always thought it never happens, but I think if we culture early, probably we get occasionally these organisms.
Okay.
And sorry, I missed out on the last. I was not able to unmute myself. The hereditary fructose intolerance. We have 2 children. One one is now 12 years going to school. She has had multiple admissions with severe lactic acidosis, but never had severe these kind of changes. Even the other child, who is now around 7-8 years, she is also fine, going to school regular, no cognitive issues. Each time they come out very well. So I'm not sure whether we can attribute everything to hereditary fructose intolerance here. Is there a way to attribute the reason? I'm not sure.
And Dr. Lokesh, I remember what the patients which you are saying. I think the patients which we had, they used to very meticulously follow diet and all, but during every febrile infections, they used to deteriorate and come. I'm not sure again whether this again would be a primary infectious process indicating the MRI changes, but she just happened to deteriorate with because of underlying condition.
Yeah, sure.
I think it's maybe the response of the inflammation in these children, because the first child also died few years back in a viral infection. So these two children might have the same virus, but that child won't have the same virus and died within 24 hours. So maybe their inflammatory response, or maybe the amount of toxins which go up in these children in everybody is different, especially those who are not compliant. Yes. Because one of the siblings who died was 2 years back.
Yeah, possible. I think that it indicates that very aggressive monitoring, having an emergency protocol for these children, and insisting on the dietary, this one is extremely important, which will have an outcome between death versus a good long-term outcome.
I can see Sanjay on the panelist. Sanjay, you sent some message on the group, on the chat. Do you want to make any comments for the HFI case?
Yeah, sorry. To say there's a Cochrane review on acute meningitis and steroids, and there's no harm. It can reduce hearing loss. We've seen this in our own experience here, and also it reduces inflammation in the subarachnoid space. But we reserve it for the most sick children. We don't give it like this kind of kid. I think it's reasonable to give it under monitoring. And the last thing is when you're doing imaging, make sure you look at the inner ear structures, because enhancement there is a harbinger of hearing loss. So something that we always add into our meningitis sequences to look at the inner ears.
Okay.
Yeah, that was useful. Thanks.
And the empyremas you say are not large enough for.
Right, that's a neurosurgical call. If it's small and the child is stable, that's important. The child should be stable, then you can watch. If the child is sick, then and your neurosurgical colleagues are happy to go in, then taking pus out is always a good thing. But it's between a balance between, we are towards surgery because neurosurgical care is really good and they are very happy doing it. But if you are not sure, the risk and benefit has to be weighed in. But we usually go in and take most things out, unless the kid is very stable and it's a very small empyema. And the last thing is the inflammation that you see here. That's a bad sign. Dr. Bolthauser just said this is a bad prognosis anyway. So steroids will only probably help you here than not. So you're reasonable giving it.
Yeah, thank you.
All right, thank you. Next case from Romit. Romit, if you're there, you can present the case. Okay, I think he is not there. I'll go ahead with the presentation. So this is a 4-month-old boy. So at the age of 2 months, he was evaluated for recurrent lower respiratory tract infections and diagnosed as having multiple VSD with severe PAH. Underwent PA banding at 3 months of age and was uneventful. Had mild delay and progressed after surgical procedure. Now presented with acute life-threatening event in the form of fever, vomitings, multiple episodes of seizures. On examination, child was at microcephaly with severe failure to thrive and mild hepatomegaly. Sparse hair with poor neck control, poor tracking, and hamstring spasticity. The CRP was high. Chest X-ray demonstrated change of pneumonitis. 2D echo had directed RA-RB and a left to right shunt with VSD. Urine ketone was normal. VBG was demonstrated mild metabolic alkalosis. CSF analysis was normal. Lactate was mildly raised, and the LFTs were significantly raised, over 1,000. So the imaging was done. These are external films, and we have the diffusion and ADC sequences. And you can appreciate symmetrical areas of changes in the bilateral global paradigm and also the cerebral peduncles, demonstrating low signals on the ADC. There is a degree of volume loss in the supratentorial brain parenchyma. Posterior fossa volume is normal. Cerebellum, there are no obvious abnormal signal changes. So child was sent for TMS Before I go to the TMS reports, these are few differentials for the, we concentrate on the globus pallidus, the changes. And on TMS newborn screening, the child had a diagnosis of medium chain acyl coenzyme A dehydrogenase deficiency. The child has been sent for genetic analysis, but this was the TMS report. I could not find any cases in literature which demonstrated these similar changes, at least on the neuroimaging aspects. But it comes under the fatty acid mitochondrial disorders, and this is from the mitochondrial disease compendium, and they described changes of CNS manifestations such as seizures, hepatomegaly, which was seen in our case, and hypoketotic hypoglycemia. At this moment, I'll open the case for the panelists if they have any experience with the MCAD deficiency and the clinical and imaging manifestations.
Actually, MCAD is a pretty common fatty acid oxidation disorder. Almost 1 in 8,000 or so is the incidence, I think, I'm not sure. So most of them present with the fasting hypoglycemia, non-ketotic, and that's a usual clue. And when adequately managed, generally they don't tend to have any long-term issues. They do pretty well unless the hypoglycemia of hypoglycemic brain injury. Otherwise, they don't have any significant imaging findings, characteristic imaging findings.
Okay.
But this might be the characteristic finding, right? Because
yeah.
nothing else will explain it, right?
So he has sent it for genetic analysis, but just to ask others if they have any experience with.
Can I have a question to that slide before?
Yeah.
It's newborn screening, but this was the screening done at the age of 4 months. Am I correct?
Yeah. I think it is known as termed as newborn screening, but we can do it later on. Is that right, Dr. Lokesh or Dr. Vivek?
In many countries, the MCAD is included now in the newborn screening. It has a rather high prevalence.
No, what I assume is, again, the child did not have a newborn screening at the time of birth, but I think after the presentation, he was sent for newborn screening or a tandem mass spectroscopy.
Okay.
Yeah, so we do not have a national, at least for the whole country. There might be some states, newborn screening program. And even if it is there, it doesn't include these metabolic disorders. So these tests are done when the child comes to you symptomatically, and then you pick up. So even though it says on the top newborn screening, because the same card which is used, but it doesn't mean it was done in the newborn period. So we don't have a national program for that.
And also not a local one, or for your country, for your area.
So most of the local ones still, because of the population and the cost involved, they cover thyroid, congenital adrenal hyperplasia, and yeah, 2 things mostly, and cystic fibrosis at some places. That's it.
Okay. Any plan to introduce a newborn screening? I'm not criticizing, I'm just questioning. Because some of these conditions, like, for example, congenital hypothyroidism here, has a prevalence of 1 in 3,000 newborns. And this can be effectively treated by prophylaxis. Otherwise, it's a very serious condition. The same for PKU and so on.
I think the initiatives are in process, but because there is a lot of federalism in the country, so it's not just a single country. It's a mixture of countries in a way, with a lot of, so it's very difficult to make a consensus for the whole country. One is consensus. Second is the numbers and the investment to have all the labs and the people to interpret it, and the metabolic people if the results come abnormal. So it's a work in progress.
I was just asking, not criticizing.
No, you are correct. I'm just trying to reason out and trying to defend.
Switzerland,
something which should be there.
In terms of political comments, Switzerland is a very conservative in introducing new items in the newborn screening. But if you calculate the costs and what you can avoid of costs, it's a bargain. Okay, we should move on, perhaps.
Okay, yeah. Wait, thanks again. Yeah, sorry, this was the only case, which I found with the MCAD, which has edematous changes, cytotoxic edema, subcortical, involving the subcortical region and the middle cerebral peduncles. Over time, the changes have improved. So yeah. We'll move on to our next case, Kirti.
Yeah. So this is a story of a 13-year-old girl who had presented around 6-7 months back with complaints of fever. It was prolonged fever that lasted for 7 days. She was admitted elsewhere. There were no clinical localizing signs for fever, no other system involvement. And that time she had high inflammatory markers, that is high ESR CRP. Blood cultures were negative and there was no focus of fever found. But she was treated with IV antibiotics empirically and she responded. And when they repeated the inflammatory markers at an interval of every 3 to 4 days, they showed a decreasing trend. And that's where she was discharged. But after she went home, for 7 days, she was fine. But then after that, she started complaining of headaches, which were very severe. And along with headaches, some fever restarted and she also had vomitings, and then suddenly had an episode of seizure, which was focal in nature, right focal seizure. And after that, she became totally encephalopathic. Now, at this time, she had to be intubated after she became encephalopathic. She had right hemiparesis, she had right human facial palsy, and we can go ahead with the first scan done at this time.
So the first scan was done in December 21, and on top are the diffusion and T1 weighted non-contrast sequences. You can appreciate that there is areas of restricted diffusion and a hemorrhagic lesion in the left parietal region extending up to the sylvian fissures and the perisylvian region. T1, the hemorrhagic components are demonstrated as the T1 hyperintense foci with areas of blooming on SWS sequences, and there is some degree of perilesional edema. Venogram MRV did not demonstrate any abnormalities, but there was this foci of a cortical vein which was almost reaching up to the lesion, likely the superficial middle or the sylvian vein, which demonstrated a foci of blooming. So a possible thrombosis was suggested. Taki.
Yes, sir. So with this evidence, we started her on enoxaparin. By day 5, day 6, her encephalopathy improved. We could extubate her. And after that also she had some periods of recurrence of seizures, some worsening of sensorium in between, on and off fever. So it was a very complicated picture. It took her 1 month in the hospital to stabilize before discharge. But at the time of discharge, she was afebrile for 3 to 4 days. But then she went home and she came back again after 1 month. And now the chief complaint was that she is not able to see with her left eye, and she had completely lost vision in left eye. There was only perception of light, not even finger counting. Right eye also had diminution of vision. And fundus examination at this time revealed a hyperemic disc, which indicated that there is some inflammation, either infective or inflammatory, but the disc was hyperemic, indicating some inflammatory changes going on. So here we repeated a contrast scan. MRI contrast with orbits were repeated here.
Okay. So again, you can appreciate the lesion. This is almost after a month. Again, the edema has progressed in comparison to the prior lesion, extending up to the frontal lobes and the basifrontal region. There's also a edematous changes or infiltration into the mammillary optic chiasm optic tracts on both sides. Again, the hemorrhagic components are present on the SWI sequences. On post-contrast study, there is an irregular peripheral enhancement along the sylvian fissure, the lesion along the sylvian fissure or the perisylvian region, and some degree of leptomeningeal enhancement. Coming down to the optic chiasm and the basal cistern, you can appreciate this thick leptomeningeal nodular and ring-like enhancement in the basifrontal regions. Also in the superior vermis, some tiny areas of peripheral enhancement. Better appreciated on the sagittal images. The interpedunculair fossa also demonstrates this thick leptomeningeal enhancement. So it is involving the optic chiasm and the basal cisterns, giving a picture of a optochiasmatic arachnoiditis. So at that point, possible etiology of tuberculosis was suggested. Kirti?
Yes, so here we thought of tubercular. So actually in the first admission, when the fevers were going on and off, we had thought clinically of tuberculosis causing an hemorrhagic infarct. But the only thing positive which we had got was a Monto positive in the first admission, which we repeated in the second admission. Still it was positive. But in the first admission, we couldn't do CSF because of the midline shift. So with this second presentation, we did the CSF, which showed only 20 cells with almost normal protein and sugar. Gene expert was negative CSF. PCRs, bacterial and fungal PCRs were negative. So we didn't have any bacteriological evidence for tuberculosis, but still with that MRI picture, we went ahead and gave pulse steroid for 5 days and antitubercular therapy. Now, after giving pulse steroid, by day 5, her vision improved. From perception of light to finger counting, which further improved after going home in 7 days and was almost back to normal in 10 days. So her vision had drastically improved after giving steroids. So she was followed up with this antitubercular therapy and steroids. And on repeat imaging, the exudates appeared little bit better. The lesions appeared less enhancing. So hence steroids were slowly tapered and stopped. But within few days, that is almost 7 to 10 days of stopping steroids, she became symptomatic again. She started complaining of similar headaches and vomitings. And she came back because she used to feel very dull, though she didn't have a new focal deficit, but she was symptomatic with mainly headaches and vomitings. So we repeated the imaging at this time again to see what was happening with the lesions, and it showed little bit worsening of the exudates. So as compared to the interval imaging in the second one, the third one appeared similar to the first one. So on tapering steroids, actually the exudates and everything had worsened.
So I have the last scan, not the one prior to that, in April 22. Again, you can appreciate the areas of abnormality in the perisylvian region. Again, this peripheral enhancing lesion in the sylvian fissure, and you have the multiple peripheral enhancing lesions in the basifrontal region, the interpeduncular fossa, and this thick nodular enhancing foci along the basal cisterns.
So here we had thought of possibility of iris immune reconstitution syndrome, which can happen on tapering steroids. So we thought of starting steroid sparing drug, that is thalidomide. And also we thought after discussing with Dr. Lokesh, after discussing with Dr. Lokesh, we thought even infliximab, if it could have a further immunomodulation role. But before that, we wanted to be sure of a bacteriological evidence of tuberculosis, and hence we went ahead with the biopsy of these lesions. So this was the biopsy slide, which actually showed multiple yeast cells, to our surprise, which were morphologically of 5 to 10 micron size. And the culture from this sample, of the biopsy sample, was negative. And though we couldn't do PCR of this biopsy sample, but the gene expert and the fungal culture, that couldn't show any growth. So we don't know whether it was what type of yeast cell, most likely Streptococcal, Candida, or Exophyla. These were the differential of the fungi given. And so right now we have started the child as well on antifungal treatment.
I'll directly open the case for discussion.
Did you do galactomannan in the CSF for blood?
We have sent galactomannan, serum galactomannan we have sent. And serum Streptococcal antigen also we have sent. The infectious disease specialist advised to also send beta D glucan levels in the serum. That is actually costing a lot, so that we are not able to send right now. So right now, so this was the main question, whether fungal, how much sure, of course biopsy is showing fungus, but the imaging, early imaging clues of a fungal etiology mimicking a tubercular. So can fungus present with such thick basal exudates mimicking tubercular infection? That was the main question.
Sorry, this is Kate. It can.
Yeah.
Okay.
We had a recent case here as well, similar.
Okay.
And presence of blood suggestive of an angiocentric invasion. Is that right? The first one showed blood on the left side.
Yes.
So aspergillus has to be really ruled out. The only thing usually in the CSF sugar is quite low, like in tubercular infection, which is not, but maybe it's still localized, so as not to cause this. Beta-2 glucan, that is more for a fungal infection as a whole, and maybe more for candida as a screening. Galactomannan is more for aspergillus, so it will be useful to see.
We even did this test for this child to look for any lesions there, but all she had were calcified granulomas. So we couldn't do any, if there were any active lesions, we could have done at least a BAL, but because of the calcified lesions, we were not to do that. We were not able to do that.
This is a very big problem because in operation theater, if there's any contamination, it will come as yeast. Anything from the cotton, or you can never be sure with the yeast when you take a biopsy.
Okay.
Even small contamination.
Okay.
I may have missed your point. What is now your treatment approach?
Right now, we are giving both antifungals, that is liposomal amphotericin B, as well as continuing antitubercular, and with tapering steroids.
Thank you.
Would you be giving voriconazole as well, or
yes,
is that
yes,
something?
sir. So the plan for her is to give liposomal ampho B as well as flucytosine for 1 week, followed by voriconazole maintenance.
And the India ink was negative, CSF.
Sir, first CSF we didn't do India ink. We just sent PCRs because I didn't think it could be fungal at that time. And in biopsy, we discussed if they could do India ink. They said it's only for CSF. We cannot do it on biopsy.
One question about the competence of the patient, immunocompetence of the patient. It's very unusual to get fungal infection of this magnitude in the immunocompetent patient. You think the steroids could have played a role and it was something else before? Or has any other part of the body been involved? Is the spine involved, for example? It's very unusual to see this degree in a very, like a normal child otherwise.
Right, sir. At least for immunodeficiency, HIV is negative. But rest of the workup we have not done yet.
Okay.
But it does
most
come.
of our Vivek.
Yeah, but it does come somehow in immunocompetent children also. Streptococcus comes where there are a lot of pigeons, around the house. So it does come. It's just people don't report probably. So if immunocompetent can, every year 2 or 3 patients maybe.
Yeah, most of the aspergillus we had all immunocompetent adolescent children.
All right, thank you everyone. We'll move to the next case. Geeta?
Yes, sir. This child, female child, so presently 5.5 years old, when she presented to us, but the prior illness, she was fine, normal neurodevelopment, no perinatal issues. And at 4.5 years of age, she developed initially right hand dystonias and some tremulousness for about 2 weeks. Later on, she had a fever. This lasted for 1 month, and then next month she had a low-grade fever. Following the fever, after about 2 weeks later, she developed both right hand and leg imbalance and more dystonias. And even there was a right hand fine motor regression was present. During that time, she was investigated elsewhere. First MRI and EEG were done that time. In EEG was normal. And also genetics workup was done and few investigations were done. And later on, previous slides.
Yeah.
Later on, like about a month later, she again had fever. Then she developed progressive left-sided dystonias, and gradually over few months, all these like about 4 months duration, this left-hand dystonias kept on increasing, and right-hand dystonias were same the next month, and she started to develop jerks. And there was also these left-hand dystonias were associated with the pain, and right-hand dystonias became better. And later on, she had this regression of milestones, initially walking and also with the regression of standing and sitting. And presently, she has facial dystonias, following issues, increased left-sided dystonias, and minimal right-sided dystonias. And these are better in the morning and increases in the evening. Every day she is having 1-2 episodes of dystonic crisis every day. So the investigations which were done were serial neuroimagings and increased blood lactate, which was 30, and genetics which were sent was normal, like whole exome sequencing and mitochondrial panel also. And when this child came to us, we after the radiologist opinion, we have sent for the genetic reanalysis to look at the genes, but this was also negative. So we have done a muscle biopsy for this child for the histopathology and respiratory enzyme analysis. So we wanted to know the imaging differentials for this type of MRIs.
Okay. We have a series of MRI starting from 2019 January. Selected images of the CT non-contrast images. The primary abnormality was in the bilateral caudate nuclei in the form of these focal lesions, hypodense lesions. This is slightly pixelated bone window, but in that we could not appreciate any calcification. So in Jan 2019, the primary abnormality was the hypodense lesion in the bilateral caudate nuclei. November 21, focusing on the basal ganglia again, we have the changes have now progressed and involving the mid and posterior putamen. There are almost cavitatory or cystic lesions in the bilateral putamen with some degree of volume loss. And there are again changes of some patchy involvement of the subcortical and subcortical white matter, deep periventricular white matter in the frontal regions. The basal ganglia changes demonstrate restricted diffusion. On angio, could not appreciate any abnormalities. Jan 22, this is the most recent scan. Again, some areas of white matter involvement is seen in the frontal lobes, left more than right. The geno of the corpus callosum is also involved. Again, cavitatory changes in the bilateral dorsal, the putamen, and also the caudate nuclei with reduced volume. On the SW, again, could not appreciate any mineralization or hemorrhage. Again, some degree of restricted diffusion. Spectroscopy was done, and you can appreciate there is an inverted lactate peak. So based on that, the differentials for the striatal necrosis are vast. Mitochondrial, given the lactate peak, was one of the considerations. Other changes such as glutaric aciduria can be ruled out based on the other imaging findings. Huntington disease, I think the clinical doesn't fit. Mineralizing angiopathy, they usually present with transient dystonias and not recurrent or long-term issues and regression. So there were again no calcifications on the SW images or the CT scans. Other differentials are biotin, thymine, anti-D2R antibodies, and we also thought of interferonopathies. The basal ganglia disease can present with necrosis and cavitations in primarily the ADAR1 mutation, and they can also have white matter involvement. So these were the differentials we thought of, and I'll open the case for further discussion.
I have missed the age of the patient. Age at onset of
symptoms. Presently 5.5 years old, sir.
So started at around 2 years. Yeah.
No, started at 4 years of age. The first CT which was done was she had a just trivial head injury, like fall from the chair. So they got the CT done at that time.
Okay. Trivial head injury. Is it age group for mineralizing angiopathy?
It was at around 2 years of age. Sir.
Okay. Okay.
Can you get mineralizing angiopathy without any evidence of calcification on the CT? Was there any?
We have always had calcification, and caudate is not the usual site; it is symmetrical, and usually the putamen was the more common site what we had.
Totally agree with the expert there. Question: any viral prodromes before we jump into mitochondrial with this?
It is actually very slowly progressive, worsening over a period of time.
Okay.
So
my money will be on my here.
Viral over 3 years, that would be slightly atypical, Dr. Manka.
Sorry?
It's over a 3-year period. So
yeah, I missed that 3-year period.
Yeah.
I think the mitochondrial realm here, isn't it?
So I have 2 patients who were diagnosed by Manju through whole genome sequencing. So the MRI of the first child, so both of them have the same gene, PDE10A. So the first child's MRI resembles this child's MRI. The symptoms of the second child, the episodic severe dystonias, who is younger, resemble the symptoms of this child, even though the MRI is normal. So I hope I am clear. So 2 patients who have PDE10A gene. This PDE10A gene causes similar striatal changes. In the older child, the 10-year-old presented with severe chorea with these striatal changes. PDE10A was picked up by Manju. So that's fine. So that matches. The second child who has this history as this patient, severe episodic dystonias every day, especially at night time, throughout the night. And she's now 6-year-old, started at 1.5 year age, every day dystonic episodically, and in between she was so well. Her MRI is normal, and she also has PDE10A, and that's new. That's a new. So people haven't reported it. Episodic dystonia, normal MRI, PDE10A. Is that I'm clear? Is it? Am I clear? Yeah.
Yeah, clear, Dr.
Yeah. So the MRI changes, like the 10-year-old boy who presents with chorea. These MRI changes, but the symptoms of the younger child, like this patient, but the MRI is normal, and both have PDE10A. So there's no harm. Manju will be more than happy, I'm sure, to do the whole genome sequencing in this child. I can give the details and stuff. It does take time to come back the results, but if you get the videos and MRI and send to Dora, her fellow, they are quite quick.
It's Dora Steele, isn't it? That's the
Dora Steele.
Before the pandemic. Is she still collecting cases? I'm happy to connect you.
Yes. Last week I sent one, so she is.
Perfect.
So that's a case of Dr. Lokesh. So Dr. Lokesh, maybe you can.
So PDE10.
Got it. All right. Thank you, Dr.
Yeah, thank you.
What's that?
Did you publish your cases?
Was that, sorry?
Did you publish your series when you got the
they are publishing. So they discovered the genes for me. So I'm one of the co-authors. So yeah, they are going to, I think, publish it.
Got it. Perfect.
Yeah.
All right. Last 2 sets of cases. Sahil?
Yes, sir. She's a 3-year, 7-month-old female child with normal perinatal and developmental history. So she presented initially with an episode of seizure on 4th of June. That was a focal fever-provoked right-sided focal tonic-clonic seizure, and she was managed as a case of complex febrile seizures initially, and she was started on Frisium SOS, and she was then on discharged. As soon as she was discharged, she got a second episode of seizure with same semiology on 6th of June 22. and right focal tonic-clonic seizures. And she was then further evaluated in some private hospital outside. She had no neurodeficit as such. Her CSF showed a TLC of 25 cells, protein and sugars were normal, and she was treated as a case of partially treated meningitis. And subsequently, MRI was done on 13th June, which sir will be saying. Yes.
Yeah. Sir is not required, but yeah. So on top we have the flare sequences, and we have these patchy areas of flare hyperintensities in the subcortical white matter in the parietal frontal regions, also known in the cortex, the anterior cingulate region, and the parietal region. The perinsular region also demonstrates these, these hyperintensities. You can again appreciate a focus over here. Brainstem and cerebellum are relatively spared, but nothing on the diffusion and nothing on the gradient echo sequences. Optic nerves, I could not appreciate any edematous changes. Post contrast, cannot appreciate any enhancement, abnormal enhancement on contrast study, nothing on the perfusion. Yeah, sorry.
Yes, sir. So subsequently, this child was improving well on antibiotics and everything. So just on day 5 of the indoor, when the child was indoor there, she threw another seizure, which was same fever provoked seizure with right focal tonic-clonic. After which her consciousness rapidly deteriorated, and she was referred to Bharati hospital for further management. And in view of poor GCS, she was intubated with proper neuroprotective measures. And her bedside EEG, which we had showed excessive beta activity, no electrical buildup was seen. And we reviewed this MRI, the previous MRI, and it was given as edem, likely suggestive of edem. So CSF biofire was sent, which was negative. CSF for tubercular gene expert, that was also negative. So we gave her methylprednisolone for 5 days, and after which now the child is conscious, well oriented. Her seizures have stopped. She's GCS has improved. She's bowel bladder function has come back, and there is much more improvement. So we plan to do an MRI with brain screening for seeing the improvement of the lesions as they were there previously. So the repeat MRI, which was done on 26th of June. Yes, sir.
Yeah. So from 26 to 17, there's no seizures or any acute presentation. Is that right?
No, sir. No. Now currently the child is well. GCS is 15/15. Taking feeds well. Good bowel bladder function, and is able to walk with support. Yes, sir.
Okay.
Yeah.
So again, these are the MR pictures of 28 June, and you can obviously appreciate significant progression as compared to the prior study. Restricted diffusion in the subcortical cortical regions in the bilateral cerebral hemispheres, predominantly in the parietal and frontal regions, and the right cerebral hemisphere involving the frontal perisylvian and the temporal regions. Bilateral temporal regions are again affected. Some degree of occipital lobes also demonstrating restricted diffusion. And on flare, you have this diffuse edematous changes, predominantly in the subcortical and cortical regions of the affected portions. Post-contrast study, again, cannot appreciate any significant abnormal intracranial enhancement in the abnormal areas. Spine, no focal lesions on the spine. Spectroscopy is non-diagnostic. There are some small lipid and lactate peaks. Choline, creatinine are normal, nothing diagnostic. So based on the imaging, we thought of possibility of a ADEM phenotype related to MOG antibodies. They can present with these large confluent lesions. The only typical finding was the cortical or the subcortical restricted diffusion, which can be seen in the MOG-related encephalitis. Other autoimmune etiologies were also given in the differentials. The cortical encephalitis panel as demonstrated here, but I'm not sure if the restricted diffusion is common in these autoimmune disorders. Status epilepticus, given that it was at around 7 days prior, but they can also present with a cortical involvement. The only abnormal thing for this status was the subcortical and diffuse confluent white matter abnormalities. So at this point, I'll open the case for further discussion.
If Yale is still at the meeting, we would like to know from her what she thinks.
I know, but I had a phone call halfway through, so can we just give a brief recap of the case? I'm sorry. Oh, perfect.
Yes.
And the scan?
Yeah, Sahil, quickly.
Yes, ma'am.
No, because this bit I got, and then I had a phone call.
Okay. Yeah, so after that bit, this was the MR.
Yeah.
We had this patchy involvement in the subcortical and cortical regions, bilateral cerebral hemispheres. Nothing
and
on the
MOG was
diffusion.
positive or negative or not done?
No, they haven't not done yet.
Okay.
The child is, I mean, they are slightly.
That's like financial issue.
Yeah, financial issue. So they wanted to pinpoint a particular test to be done. So after that,
if I had to look at one test, I mean, I don't think this is an NMDA encephalitis clinically. NMDA is, although we've seen a few patients with some MRI imaging, this is clinically no NMDA encephalitis, so I don't think we should use our money for that. It does sound acquired, the cell count in the combination of seizures and things. I mean, I do think MOG is probably the most likely, but also this could also be one of the seronegative. So if in a way you will probably treat it in a similar. Oh, sorry, that's the second scan.
Yeah, that's the second scan, and the child.
Yeah, so I think you're left with MOG as one option. I think that the second option, we've mentioned those things before, that sometimes we got caught are some of the HLH and things, but these children are normally much sicker, no, than what she is now.
Yes,
yeah, she's perfectly fine, I guess.
Exactly. So back to that discrepancy. Sorry if we keep going back to the same point. If you see like one of these horrible scans and the child is only a bit sleepy and not quite right, but actually walking and doing things, and I think MOG is very high on the differential. I don't think this is going to be. Sometimes you kind of worry with these type of cortical changes. Could it be some of the slow viruses and things? And I will leave it to you guys in case. You can think of anything endemic, but if she's immunocompetent, then I think this is all very unlikely to be that. So I would have thought MOG is the most likely diagnosis. If the parents are really struggling financially, you could argue that actually you can just treat it as an ADEM, I would have thought, and see how she does, irrespective of the diagnosis. But if you have one test, I think the MOG is probably the one to do. And that cortical rim, I mean, it was the first paper that they described, the Japanese did, and I think what we see in children is that they get a bit more. It's not just the cortical rim; they get more involvement, and if you leave it a bit longer, you may extend even more without treatment. So I mean, I feel it's in keeping with probably MOG highest as a differential, and if she would have been more unwell or in any other risk factor, I think. You can think about other things. I mean, it doesn't look infective. The cell count, we see it quite frequently in MOG patients, so it doesn't take away from that. And I think actually historically, many of these patients, particularly with this cortical involvement, because they had raised cells in the CSF before we started doing the antibodies, they were all being labeled as viral encephalitis because somebody picked up some virus somewhere else in the NPA or the. So I think it's if you look at some of the textbooks, you can also see some, or even papers, you can see some virus has been reported at that. But in fact, if they haven't done the MOG, then it's I think the MOG is likely to be the pathogenic here and not a respiratory virus isolated somewhere else.
Got it.
Kish, what do you feel? Kish?
Yeah, totally. I agree with that. I think that's kind of where we were inkling towards as well. But I don't know what the final results here were.
And sorry, and the other thing that again would go very much with MOG, because I'd be grateful for radiologists to help me with that. But to see such a quick radiological progression across the two scans is again, I mean, I'm not aware that there are many conditions that do that so quickly. In the absence of the child, really deteriorating. No? If you compare the first scan and the second scan, that's something that we see a bit more with a kind of even MOG and ADEMS versus other conditions.
It's 2 weeks basically between the two scans. You're right.
See how impressive is the change in the absence of clinical deterioration.
Okay.
Yeah,
So we'll be.
And we were just discussing it just for the learning point. We were discussing it because they're trying to develop radiological parameters to differentiate between MOG and ACO.4 and but in this condition, if you would have used the first scan versus the second scan, it's totally different areas. So Kish and I keep telling them that they shouldn't just look at what areas are involved, because you get so much fluctuation, then it makes no sense to use one area because your sensitivity is not going to be accurate if there's such a variability by how quickly the scan progress according to the day from symptom onset you scan the child.
I had a question about the spine. Nihaal, I know you showed us some sagittals. Did you have any axials through the chordae equina? Were they thickened at all? The bladder
no,
quite distended, but I know they're not enhancing, but they looked a bit thickened to me on that sag. Not sure if that was corresponding.
No, they didn't enhance on the axils.
No, okay, that's fine.
Yeah.
And the spectroscopy that you were showing there, did it show any choline peaks at all?
It does.
It shows a reduced NAA peak. That NAA
Reduced
with choline is 1:1, which means it's equal. The NAA is reduced, the choline is still preserved, but it's not from the areas of the most involved areas. You have to see where the thing contains lots of normalish matter, gray matter, more medially. You probably need a smaller voxel to get the area of choline degeneration. The optic nerves were normal on the second scan. Okay, I missed the optic nerves on this.
Looked okay on some of the.
On the first scan, they were normal. Second scan, they were also normal. They were not. I don't have the slide, but yeah, it is normal.
Yeah. I think the new term is flames, isn't it? Flare-associated lesions in MOG with seizures.
Ouch. Yeah. I don't think we use it here.
Oh, okay. That's if they have seizures and that kind of flare, hyperintense.
You're right. It's flames and God knows, and a few more things after that. Flames with flares. I mean, there's another term.
Sure.
Is primary CNS vasculitis a possibility here, and acquired in India, SSP and retrovirus?
So SSP, I did think with that kind of cortical thing, but actually you would expect a child with SSP, with this type of MRI to be much, much more sick, no?
Again, in SSP, often they are not.
The change of the interval change is slightly atypical for SSP, I would say, on imaging at least.
And the EEG is normally diagnostic, no, for SSP.
Yeah.
So, but for CNS vasculitis, again, it's a bit difficult because I think a lot of the early cohorts that the Canadian group have published, many of these patients were in fact MOG positive. There was a paper by Thai Salman a couple of years ago highlighting that actually a patient that looks very similar to that even when they looked at the brain biopsy, you can see some vessel involvement, but you don't see the laminal necrosis that you typically see in adult vasculitis. And actually, this type of imaging picture is not typical for adult vasculitis. It's just that some of our pediatric vasculitis were described like this, but they in fact were never vasculitis. They were MOG. And the important thing is that many of them have relapsed on cyclophosphamide. So this is how. So we had a few from the UK that were historically being called cyclophosphamide, and we later on picked up the fact that they were MOG, and interestingly they relapsed on cyclophosphamide and cyclosporine and many other of the vasculitis treatments. So it's just kind of highlighting the importance of not overcalling them and treat for that. I think CNS vasculitis in children, or isolated CNS vasculitis in children, is incredibly rare. I've yet to see one patient I was totally convinced by it from the brain biopsy.
That's very
unless it's in the context of lupus or something like this.
Yeah, we just have a paper at the annals coming out soon on vasculitis. I thought kids started having vasculitis but having alternative diagnosis, and MOG and HLH were the top two that we found in the biopsied patients, the 30 odd patients that we're publishing now in the annals. And
I'm so happy publishing it. I'm looking forward to read it. Actually, if you can send it to me, I'll be. I didn't get to review it, but yeah, wonderful paper. I think it's very good to highlight. Yeah.
Yeah, so the other thing was the enhancement pattern here doesn't look like vasculitis. This post contrast you have on the screen right now doesn't look like there's enhancement at all, which is very unusual for a rip-roaring vasculitis. Looks more like MOG in every respect, looking at the series we just reviewed.
Just to point out, the next case is an SLE case.
Oh, good for us to learn.
Yeah. So all right, we'll move on to the next case. Thank you. Yes, I.
Yes, sir. Thank you. She's a 12-year-old female child. So she was normal till 10 years of age, and she was eventually diagnosed with SLE with juvenile dermatomyositis in 2020. And she's been subsequently receiving steroid, mycophenolate mofetil, and HCQ, hydroxychloroquine also. So she presented to actually to a private practitioner elsewhere with complaints of fever, cough, and colds with weight loss since 1 month, and during which fearing that the mother eventually stopped her steroids and immunomodulatory therapy, and after which her lesions flared up, and eventually she was referred to our hospital for further management, and she was doing well on admission. During that time her GCS was good. There was no neurodeficit as such in this child, and in ward on 26th she had an episode of generalized tonic seizure with uprolling of eyeballs, and after which her consciousness immediately deteriorated and electively intubated with proper neuroprotective measures which was started. So before that her gene expert for tuberculosis was sputum was also sent, considering there is a complaint of fever, cough, and cold since 1 month. So it turned out to be rifampicin positive sputum tuberculosis, pulmonary tuberculosis. Yeah, and her subsequently she was intubated with the hypotonia. There was absent deep renal reflexes with bilateral plantar flexor. So the MRI was done on 26th. That the same day that she got a seizure.
Yeah. Okay. So on the MR, on the flare axles, we have cortical, subcortical hyperintense changes involving the bilateral, frontal, parietal, occipital regions. Mildly reduced volume of corpus callosum, but nothing significant. Nothing on the, I would say probably some areas of hyperintensity on the diffusion weighted sequences on the DWI and the cortex. I'm not sure if they correlate or with the ADCs, but at least the parietal occipital regions demonstrate facilitated diffusion. No hemorrhage or calcification on the SWI sequences, but on post-contrast imaging, you can appreciate this almost diffuse extensive leptomeningeal enhancement involving the affected areas, bilateral, frontoparietal, and occipital regions. No basal exudates or basal leptomeningeal enhancement in the basal systems. So on the angio, cannot appreciate any abnormality. The PCA was hypoplastic on the source images on the right, but no irregularities or bleeding or stenosis. The neck angio also was normal. I think it was reported as PRES initially, though I would say the contrast enhancement pattern is slightly atypical for PRES, though can be seen but not as extensively as seen in our case. Other possibilities were the CNS vasculitis given the SLE history. And the leptomeningeal enhancement can also be inflammatory tubercular, but given the absence of the basal exudates, I think possibility of CNS vasculitis related to SLE was considered, and I'll open the case for further discussion.
One thing I forgot to mention, sir, during the scan, her BP was at 90th centile, sir.
Okay.
So I've seen PRES with SLE and vasculitis all in the same patient. So it's very similar to this one, but SLE was the patient was known to have SLE. The enhancement pattern is not only just leptomeningeal, but see it's kind of a very much more thicker, looks almost like fluffy enhancement. Yeah. If you see it in a smaller area, even vasculitis looks like that as well. So looking at the series or just reviewing, if you have that kind of fluffy enhancement, little clouds around it, that's more different from just leptomeningeal enhancement you see in regular PRES. Sometimes you see just enhancement from the seizures, for example. This is very different. This is much more thicker, much more florid. and this is either infective or vasculitis. Those are the two in this particular patient would be the two, and you just told me that there's no basilar involvement, so it's most likely vasculitis.
That's right.
And the vessels may not be narrowed initially, but if you repeat the scan, you might see bleeding very peripheral. It can be hard to pick it up, but in very peripheral, you know, on the source images, you might see narrowing and in the very peripheral part of the vessels.
Got it. Okay.
Question: can you blinded to the story and looking just at the picture and the nodularity of this, can you take away carcinomatous leptomeningeal disease entirely out of the picture?
Isn't it very symmetric? It's a little symmetric. It's just only posterior. That definitely could be, obviously, but the fact that you have this posterior type involvement, no involvement of the central areas, it's sort of posterior, and you have the history of you need the history here, obviously, but it just shows blinded and anybody, yes, any infection or any neoplasm also could cause this as well, I guess.
So
if you have such a meningeal involvement, you should really pick it up on the cytospin, or is the sensitivity of that would be quite low? In the LP, I mean, the LP didn't show any atypical cells, no? Or you worried? Did the LP show any atypical cells?
No, it was not showing atypical cells. It was just showing one cell that was lymphocyte predominant. And along with that, the sugars were 38 with proteins of 122. So that was even pointing towards a tubercular, towards tubercular side.
I think just the one comment, and I think, you know, Kish may comment because we had a similar case. Sometimes when you see those, you know, vasculitis in the context of systemic vasculitis, you can have exactly that point of vasculitis and press. And we've seen a few of them, and there's been that kind of argument, is this press, is this a vasculitis? And in a way, you know, it's probably the two of them together. And it may be that the press is contributing to the hemorrhagic changes, or at least modifying the picture. So I would anyway clinically make sure that the blood pressure is well controlled, because these patients are quite tricky to control their blood pressure, and not to particularly when you start giving them steroids, then it becomes quite difficult.
Okay.
Okay. So, right. Thank you everyone. If there are no further comments.